Thank you, and I'm very honored for the opportunity to present this very exciting topic about CAR T cell therapy for multiple myeloma. Unfortunately, I was not able to be there, and thank you again, Arthur, for this amazing invitation. Here you can see my conflict of interest. The survival of patients with multiple myeloma has improved significantly in the last years. As you can see, for example, in our series from Hospital Clinic in Barcelona, in your left. Um, However, the majority of patients still will relapse or progress, eventually developing a refractory disease. The prognosis or when refractory to the main three groups of drugs is very poor without a clear standard of treatment and a very short survival. Immunotherapy has contributed significantly to the improvement of the patient with multiple myeloma from immunomodulatory drugs, monoclonal antibodies, and more recently bispecific and CAR T cells. BCNA, B cell maturation antigen, due to this restricted expression on plasma cells, has been the most targeted antigen when using immunotherapy. CAR T cells, among all the options that we have in immunotherapy, probably are the new hope for the treatment of the heavily treated population of patients with multiple myeloma, and with the most consolidated results until now. Myeloma in general are always targeting BCNA, in general also using 4-1BB as a co-stimulatory molecule. However, other antigens have been explored, for example, SLANF7, CD38, or GPRC5D. Two CAR T cells have been approved for clinical use in the US and Europe, ide-cel and cilta-cel, with impressive results in heavily treated patients. They have difference in the affinity domain in the single chain fragment variable. One is murine, ide-cel, and the cilta-cel is derived from llama. And the co-stimulatory molecule is 4-1BB in both. From the beginning, from the first result, even from the NCI, CAR T cells have shown a very deep responses in patients with refractory multiple myeloma, with in general more than 80% of the patients showing some degree of response, and the vast majority achieving at least a very good partial response. However, of course, there are several toxicities. Cytokine release syndrome can occur between 1 day up to 7 days in the case of ide-cel and cilta-cel, respectively. In general, lower grade than in the CD19 CAR T cells. And also, neurological toxicity have been observed, particularly could be acute, like in the CD19 CAR T, usually also lower frequency and lower grades, but some late neurotoxicity has been also observed in the with a Parkinson's syndrome, like more frequently after cilta-cel infusions. This activity with deep responses, even with a negative minimal residual disease, has a clinical impact on progression-free survival that could be different according to the degree of response, longer for patient achieving complete remission as usual. And that is translated into a relative very long survival when we compare with the standard of care in several retrospective studies, with almost 20 months for patients with ide-cel, and non-reach after more than 2 years of follow-up in the case of cilta-cel. However, many patients will still relapse after this treatment, and some mechanisms have been explored. One is the antigen escape of downregulation, where some subpopulation of cells, of malignant plasma cells, could be a reservoir of BCNA low or BCNA negative cell that could be the origin of the relapse. Very few patients can develop a complete refractory disease due to homozygous BCNA gene deletion and with a disappearance of the serum BCNA, and with a disease that is going to be completely refractory to any BCNA therapies. Some patients even have been described recently, a mutation that could be also be in the extracellular part and could be related to refractory. With these results on a strategy, for example, GPRC5D targeted CAR T cells has been demonstrated to rescue mice with a BCNA negative tumor escape model. While I was in the Memorial Sloan Kettering Cancer Center as visiting investigator, we were exploring dual targeting strategies to prevent this antigen escape. And some different strategies can be developed to treat these patients using two different CAR T cells, expressing both a receptor in the same cell, or even a tandem CAR T that could be targeting with each single chain fragment variable a different antigen. We focus on GPRC5D, that is a molecule that is highly expressed in multiple myeloma and with a limited normal tissue expression, basically in the hair follicle in the skin. And now there are results with advanced results with bispecific antibodies targeting this antigen. In our model, a dual targeting model, we have bicistronic system expressing both receptors in the same cell. Showed that it was more active in BCNA negative and BCNA positive model, mice model, because it can increase the ability for dual expressing target cells. And a clinical trial using two CAR T cell against BCNA and GPRC5D is just starting. GPRC5D, this strategy could avoid the relapse and delay the relapse, or even potentially to increase the cure fraction of some patients that could be treated with CAR T cell against both antigen. There are some results presented about GPRC5D with clinical responses in patients with refractory multiple myeloma, even in patients that have received previously BCNA CAR T cell therapy or then BCNA targeted therapies. However, we know that the CAR T cells, BCNA CAR T cells in patients with multiple myeloma usually last only for several months, and the disappearance of CAR T cell could be a very important mechanism. And one of the idea was to create CAR T cells with less immunogenicity. For example, having a human or humanized CFV, because we know that, for example, like the cell and cilta-cel are coming from other animals. And we presented recently our results in our academic CAR T at the Presidential Symposium of the EHA. And I'm going to comment a little bit about our results on RE2H, these humanized CAR T cells against BCNA that was completely developed in our institution. This CAR is a 4-1BB based CAR T with a humanized single chain variable fragment directed against BCNA, which has proven in vitro and in vivo efficacy. The primary endpoints were safety, cytokine release syndrome, and neurological toxicity rates, and efficacy in terms of overall response rate. This pilot clinical trial was performed in 5 Spanish centers. Clinical coordination and vector viral production were performed in Barcelona Hospital Clinic. CAR T cells were produced in 2 facilities, in Barcelona and in Pamplona, and the 5 centers recruited patients, performed the apheresis, and treated locally their patients. Here you can see the main inclusion criteria, where age up to 75 years old, measurable disease, and at least 2 previous line of treatment with prior treatment with proteasome inhibitor, immunomodulatory drugs, and anti-CD38 antibodies. We have our experience, our institution treating patients against against CD19, fractionating the dose in 3 fractions in order to reduce the toxicity without problems about efficacy. Thus, in our RE2H trial, patient received after lymphodepletion a first infusion of 3 million of CAR T cells per kilogram, fractionated into 3 doses. A second non-fractionated infusion as a booster was planned starting 4 months after the first infusion in patients without limiting toxicity and without progression. 35 patients were included, but only 33 production were initiated due to 2 progressions. And at the end, 30 patients were successfully infused after 2 additional patients progressed and 1 died. 50% of the patients required bridging therapy. The main characteristics of the patient are shown in this table. With a median age of 61 years old, 1/3 showed high-risk cytogenetics. They have received a median of 4 previous line of treatment, all were triple exposed, and 87 have received an autologous stem cell transplantation. Median manufacturing time was 11 days without production failures. 24 patients received 3 million of CAR T cells initially, and 6 patients have reduced dose due to toxicity. All patients showed at least partial response. 63 achieved a stringent complete remission, and 93% a very good partial response or better. 92% of the patients with available samples had a negative minimal residual disease by next generation flow in bone marrow at day 100, and 16 patients were still MRD negative after 1 year of treatment. After a median follow-up of 17.5 months, median progression-free survival has been almost reached. 53% of the patients were alive and without progression. That was translated into a non-reached median overall survival, with 73% of the patients alive and without after 1 year and a half. Here you can see the main results about safety. 90% of the patients shows on the cytokine release syndrome. The median onset of CRS was 8 days, and it was no grade 3, 4, 5 cytokine release syndrome and no neurotoxicity. All patients show some degree of hematological toxicity, and 3 patients developed a macrophage activation syndrome. The median peripheral blood expansion was at 14 days with a median persistence of 5 months, and 3 out of 9 of the patients with available samples who relapsed had detectable CAR T in peripheral blood. 24 patients could receive the second infusion. In general, it was no CRS and no neurotoxicity after the second infusion with a median time of 4 months. And some patients were already in complete remission, but we could see 50% of the patients show some degree of expansion. And in some of the patients also, and 6 of them, we could see an improved response. In conclusion, about RE2H, the production is fast and feasible, and response obtained are deep and sustained with relative low-grade toxicity. And in this academic humanized CAR T-cell option is a promising therapy for patients with refractory multiple myeloma. Other strategies using, for example, instead of a CFV, using a protein that is much smaller and could be less immunogenetic has been explored, with also amazing results in terms of response and even early progression-free survival results. And one of the problems has been shown in our trial and in many others is some patients cannot wait for a CAR T, and the option of an allogeneic CAR T cell is exciting because it would be off the shelf with theoretically healthier T cells and better in vein to vein. And some results have been reported with the first allogeneic anti-BCMA CAR T cells that seems to be very safe, but still the result, at least they have to be optimized because it seems a shorter progression-free survival when compared with autologous CAR T cells. There are other players in the treatment of multiple myeloma against BCMA and against other antigens, mainly bispecific antibodies that can be off the shelf with less CRS and less neurotoxicity, but also with less follow-up, and it seems in general could be a slightly lower overall response. Here you can see a summary of some of the different CAR T cells that has been explored until now, mainly against BCMA. We have some that have been approved. We don't have any available in Spain now, and other alternative control or even alternative targets. Several unmet needs has been reported in the treatment of patients with CAR T cell, manufacturing issues, the optimal lymphodepletion, treatment, for example, after CAR T cells, mitigating toxicities, and probably also the exclusion criteria of some patients, for example, plasma cell leukemia or even AL amyloidosis. Our first patient treated with our CAR was before the trial because it was a patient with myeloma with AL amyloidosis with renal involvement that is beyond 2 years with complete remission as an organ response. I'm still doing very well in my outpatient clinic. And we have heard recently in the International Amyloidosis Workshop in Heidelberg last week that other 5 patients have been treated in Israel successfully. It is a rationale for moving CAR T cell forward because we're using in generally very advanced phase, and T cell health could be better in the earlier phase of the disease. And we have in our lab demonstrated that the alternative source of fitter T cells, for example, coming from the autologous stem cell transplantation apheresis product, could be an option because ECSF is not altering the activity in vitro or even in vivo, taking out T cells from patients before and after ECSF exposure, patient with multiple myeloma, that were harvesting stem cell for autologous stem cell transplantation, and we showed that there was no difference in my survival. For that, the potential role of CAR T cell is going beyond the refractory disease and moving to first lines. And some studies are already recruiting patients comparing with the standard of care in patients for patient candidate and even non-candidate to autologous stem cell transplantation. Some challenges are associated with CAR T cell therapy, not only about disease relapse and toxicity, but also about the access in terms of time and money. And I think that the immunotherapy for refractory patients with myeloma remains one of the most promising hope, particularly CAR T cells, that we have several options with impressive clinical activity, mainly against BCNA as the most promising therapeutic target, but other targets are under evaluation. Probably the future development of these immunotherapies is still required, particularly with a fast approach to move from bench to the clinics based on a multidisciplinary teams. I would like to thank all our collaborators in the Hospital Clínica Indivas in Barcelona, all the centers in Spain that have participated in our clinical trial, and to all our patients and their families, and to all our multidisciplinary team in Hospital Clínica Barcelona was able to develop an academic alternative for the treatment of our patients with refractory multiple myeloma. Thank you so much again for the invitation.
Thank you very much. Very impressive presentation. I have actually two questions that are related more to legal and financial matters. I understand that this CAR T cells produced in academic setting are provided within hospital exemption mechanism. Is it true? The first question. And what are the financial relationship to commercially available CAR T cells?
Well, about the first question, we have already approved by hospital exemption in Spain for the our CD19 CAR T RE1 for the treatment of patients with acute lymphoblastic leukemia, adult patients older than 26 years old. And we are going to ask for the same permission, for the authorization for our RE2H CAR T for multiple myeloma, but we're still waiting for. About the commercial one, we don't have any commercial option in Spain, even if it has been approved in Europe. As you know, we have also, I was watching the amazing presentation from Canada. We have also a universal health system, and we need to have a reimbursement of the drugs, and CAR T cells are also like life drugs, and we are still waiting for approval of is going to happen. We will see the approval of CAR T cell for the commercial option.
No, but I'm not thinking about selling this. I mean, what is? I mean, if, for instance, one would try to produce such product in Poland, what expenses we have to think of for the product compared to the commercially available product?
Economically, you mean?
Yeah, exactly.
Well, I cannot say price because it's not fixed by our Ministry of Health, but I can confirm that it's much cheaper than the commercial ones.
Yeah, thank you. Are there any? Yes, please, Professor Zacha.
Congratulations for your work with academia-based CAR T cells. What was the vein-to-vein time median for your collaborative centers?
Well, we produce in 2 weeks, in general, less than 2 weeks. But the vein-to-vein was 1 month for a patient without bridging therapy and 45 days for the patient receiving bridging therapy. But it was mainly not because the cells were not ready. It was mainly because the patient were receiving still bridging therapy, and we have to wait until the patient was available for diffusion.
Okay, thank you. And the second question, do you think that moving forward this procedure would reduce the phenomenon of antigen escape in the future?
Yes, could be clearly an option because we know that usually the diversity and the subclonal diversity is less pronounced in the early phases of the disease. And probably we can have healthier cells and also a little bit less easier to escape malignant plasma cells.
Thank you.
Thank you very much.
You mentioned about a situation that some patients develop relapse after CAR T cells. Do you think it is because of downregulation of several markers, decrease of the number of CAR T cells, or it is related to genetic risk factors a priori?
at least in our experience in general, even there are some patients that are under we could see that in the patient that we have bone marrow samples in general, they have all on the except one. They show a down regulation of the BCNA on plasma cell surface when we quantify molecules in the and the relapse time. That is very important. But we are seeing also many markers of exhaustion, and some patients relapsing still with CAR T cells in peripheral blood or in the bone marrow, but showing exhaustion markers. And I think that is a very important also field, and we are trying to improve that in the lab to trying to not only to persist T cells, CAR T cells, but also to persist very active CAR T cells.
Professor Horwitsky.
How you manage the immunoglobulin depression and how it's influencing the cost efficacy?
Well, we are using more or less the standard guidelines in our institution. We're using IgG intravenous replacement when the level of IgG is lower than 400. And initially, at least for the first 3-4 months, later usually it's not required. And at least in Spain, the production is local of the immunoglobulins and is not clearly impacting in the economically.
Thank you.
Thank you very much. We have probably exhausted questions. Thank you once again. Congratulations. I think it's a very impressive data, and we hope that you will provide us with more of them. Thank you very much.
Thank you so much.